Hi, I'm Dr. Tycel Phillips from City of Hope National Medical Center, discussing the phase 1/2 study of Glofitamab monotherapy in patients with relapsed refractory mantle cell lymphoma. So in this trial, we explored the CD20, CD3 bispecific antibody Glofitamab in a patient population of those relapsed refractory mantle cell lymphoma. The study included about 31 patients who were previously exposed to a BTK inhibitor. Vast majority of those patients were refractory to this line of therapy, and 29 patients who were BTK naive. From this study, which we have previously presented some data, we noted a very similar overall response rate and complete response rate, whether BTK exposed or BTK naive patient population. And then going into duration of response, we didn't notice some durable responses in this relapsed refractory patient population. Of the two, between BTK exposed and the BTK naive patient population, we did see some longer duration of response in the BTK naive patient population. But a lot of this was likely driven to the fact that we had more COVID-19 related events in those in the BTK exposed patient population, which led to, unfortunately, 6 of 7 patients who died from COVID-19 were actually in a complete remission at the time of death, which obviously would impact the progression-free survival and duration of response of this patient population. And given such small numbers, it did overall impact those numbers. So if you look at the 15-month duration of response and complete response rate, progression-free survival, it was about 33% in the BTK exposed patients and over 50% in those who were BTK naive. If we do censor those COVID-19 related events, the progression-free survival and duration of response were actually not evaluable. Then around over 60% of those patients were alive and well at month 15. Subsequently, we did some landmark analysis which suggested that those patients who were at the end of treatment and maintained a complete response, over half of those patients had durability of response, suggesting that it could be a very durable treatment for these patients despite not having a continuation of therapy, as Glofitamab in this treatment was given for a finite period of about 8.3 months. If we switch and look into adverse events, the main side effects of this treatment would be cytokine release syndrome. We did see cytokine release syndrome in about 70% of patients. We were able to see a difference in the incidence and severity of cytokine release syndrome based on whether we gave 1 gram of obinutuzumab prior to Glofitamab or 2 grams of obinutuzumab before Glofitamab, with a decrease in the incidence and severity with the 2-gram dose. We also saw a delay in onset of CRS and a quicker resolution of CRS with the 2-gram dose. After the initial dose at 2.5 milligrams, we did see a decline in the incidence to 10 milligrams and very few incidents of CRS at 30 milligrams and beyond, thus indicating that after the initial step-up period, this treatment was relatively safe. As I mentioned, other adverse events of note would be infection, which unfortunately this protocol was conducted during the COVID-19 pandemic. We did have COVID-19 related incidents and deaths, as I mentioned. Unfortunately, this is something related to the target. Obviously, we're targeting B cells with this therapy. The therapy cannot distinguish between malignant and sort of normal B cells, thus putting these patients at higher risk for such things such as COVID-19 related events. Thankfully, as we've moved forward throughout the pandemic, we have done a better job of identifying and managing patients with COVID-19, and which we would anticipate moving forward. This would not necessarily impact patients' responses to Glofitamab. And as we have moved forward to the pivotal phase 3 trial, we have implemented guidance and sort of management strategies to help reduce the incidence of severe COVID-19 infection. So moving forward, obviously this data supports the utilization from an efficacy standpoint. And again, outside of the incidents happened during the pandemic, safety-wise, we did not see any new safety signals with this treatment. And more recently, on May 31st, this treatment was provided breakthrough designation by the FDA for patients with relapsed refractory mantle cell lymphoma who have seen at least 2 prior lines of therapy. So again, indicating that this would probably be eventually added to our treatment armamentarium for patients with mantle cell lymphoma. And we do have a confirmatory ongoing phase 3 trial ongoing, which looks at Glofitamab versus investigators' choice in patients with relapsed refractory mantle cell lymphoma.